Hi, Dr. Shwaifate.
Hello, Alicia. How can I help you?
I've had a bit of high blood pressure for a few weeks and I'm not sure.
Have you been stressed?
Sometimes.
Well, what's your diet consist of regularly?
Cocoa Pops, burgers, chips, KFC, the usual.
Okay, do you exercise by any chance?
Not really, no.
Well, this is what we can do for you. I can give you a pill of simvastatin, or I can give you a folic acid pill. I can also give you an aspirin. I can give you a thiazide diuretic. I can give you a beta blocker. Or I can give you an ACE inhibitor.
Hang on, why can't I have them all?
There are numerous risk factors that influence the level of cardiovascular disease morbidity, such as smoking, obesity, hypertension, hypercholesterolemia, diabetes, a poor diet, and a sedentary lifestyle. It's more than likely that this character is suffering from all 7 risk factors. The theory of the polypill for cardiovascular disease suggests the combination of a multitude of drugs currently used individually to assist in the prevention of cardiovascular disease and coronary heart disease events. 6 medications can make up proposed polypill combinations, including statins to lower low-density lipoprotein cholesterol, aspirin to control antiplatelet activity, folic acid to control serum homocysteine levels, and blood pressure regulators such as angiotensin converting enzyme inhibitors, diuretics, beta blockers, and calcium channel blockers. The American Journal of Cardiology has explicitly compared previous research studies that show the effect of different polypill drug combinations. The Wald and Law study significantly decreased stroke in comparison to other polypill combinations by 74%. Wald and Law's polypill combination included 2.5 milligrams of amlodipine, 25 milligrams of losartan, and 12.5 milligrams of hydrochlorothiazide. Subjects participated over a 12-week period, to which there was a decrease in LDL cholesterol by 62 milligrams per deciliter, triglycerides by 16 milligrams per deciliter, lipoproteins by 0.4 milligrams per liter, and an increase of HDL by 1.2 milligrams per deciliter. This formula could reduce the incidence of coronary ischemic events by 88%. The polypill is far from marketable at its current status. There are multiple issues that need to be addressed in relation to its efficacy and safety towards the patients and the pharmaceutical manufacturing company. The second issue is that there is a lack of understanding across the range of polypills towards their pharmacokinetics and bioavailability functions. The ranging drug concentrations and combinations require further clarification upon how they are metabolized by the patient's bodies. Take Troy, who consumes a generic polypill a day. Mario also takes a polypill a day of exactly the same formulation, but just as each individual will have varied disease characteristics, severity, and symptoms, they will also have varied responses to a generic polypill formulation. On taking this particular formula, Troy's blood pressure has plummeted, whereas Mario's blood pressure has reduced and returned to a regular and safe level. Troy's levels of LDLs have remained the same, whereas Mario's have decreased. Troy's levels of coronary artery calcium stores have remained the same. Mario's have decreased. Troy has experienced an increase in urine output. Exposure to the same amount of diuretic has not caused the same response in Mario. The third issue refers to the present negative side effects involved with the cardiovascular medication used. Long-term use of aspirin may lead to gastric ulcerations. Beta blocker medications can increase the likelihood of asthmatic attacks and coronary obstructive pulmonary diseases. The precedence of the Therapeutic Goods Administration's approval for each individual drug used in polypills could potentially ease the approval of the combination drugs. The obscurity of patients' symptoms with cardiovascular disease leads to a lack of adherence. The male on the left has no obvious symptoms of cardiovascular disease. However, his family has strong history of the disease and he is over 50 years of age and should take preventative cardiovascular medication. It is not likely that an asymptomatic patient would be willing and adherent to consuming cardiovascular medication. The lady on the left does express positive symptoms of cardiovascular disease and is more likely to develop a reliance on the medication to treat their condition, in opposed to addressing the underlying lifestyle choices which contribute to her condition, such as increasing exercise and healthier eating habits. In order for the polypill to be released for consumer use, physicians must deliberate its worthiness as a successful primary and secondary cardiovascular disease treatment. Once the polypill is refined and is established for use in treatment of cardiovascular disease, the treatment option must be communicated with the market for it to be utilized. The final issue refers to universal affordability. Developing countries cannot afford to pay this expensive advanced Western developed medication. The affordability ranged from 16.9 days mean wages in Argentina to 0.65 days in Spain. The polypill concept is in its earliest stages and may someday be a truly viable, cost-effective treatment. The idea seems to have value, and further analysis and clinical trials will ensure the safety and efficacy of such a product. It must be stressed that it does not allow society to ignore the importance of lifestyle factors on cardiovascular disease, including smoking cessation, exercise, and a balanced diet.